I'm Thomas Baldrick at the 2014 ASH Conference in San Francisco, joined now by Dr. Mikkael Sekeres from the Cleveland Clinic. Thank you, sir, for coming by.
Sure, thanks so much for having me.
Let's talk about your phase 2 study that you've got data here to present.
Sure.
What can you tell us about it?
So this is the North American Intergroup MDS study. In this study, we focused on patients with higher risk myelodysplastic syndromes, which we usually define as somebody who has either excess blasts or someone who falls into one of the higher risk categories of the International Prognostic Scoring System. And we also included patients who had chronic myelomonocytic leukemia, one of the overlap syndromes of myelodysplastic syndrome and myeloproliferative neoplasms. We enrolled 282 patients onto this study, and they were randomized to one of three arms. One was azacitidine monotherapy, the second was azacitidine combined with the drug lenalidomide, and the third was azacitidine combined with the drug Vorinostat. These patients were followed over time, and our primary endpoint was overall response rate, and we defined overall response rate by the International Working Group criteria.
And what did you find?
When focusing on overall response rate, the response rates weren't different when we compared one of the combination arms to the azacitidine monotherapy. The response rate for azacitidine monotherapy was 37%, for azacitidine and lenalidomide it was 39%, and for azacitidine plus Vorinostat it was 24%. That was the primary endpoint. We're still waiting for overall survival data to mature. We did see an interesting signal, though, in disease-free survival. Those patients who were randomized to the azacitidine and Vorinostat arm, when compared to the azacitidine arm, seemed to have a slightly better disease-free survival, though it didn't quite reach statistical significance. What we still need to do is analyze a bunch of subgroups. It appears that there may be a signal in patients who have chronic myelomonocytic leukemia who seem to do a little bit better in those who received azacitidine and lenalidomide when compared to those who received azacitidine. We also need to look at cytogenetic subgroups, and I think this is going to be key to ultimately interpreting the results of this study.
So it sounds like there's still a great deal of work to do.
We still have some more work to do, and this is going to take a few months. So as we acquire this data, we're going to try to figure out if there are subgroups of patients who would benefit from the combination therapy. We certainly haven't given up on combination strategies.
Okay, very good. Thank you, sir. I wish you the best of luck when you get back to work.
Great. Thanks so much for having me here.
Okay.